Good morning, good afternoon, good evening, dear vascular surgery and hematology family along the universe. On behalf of the Vascular Training Online Board, I would like to welcome you all in our 8th webinar meeting. First, I would like to thank Survey Company for sponsoring this meeting. And I would like to introduce my dear co-moderator, Dr. Omar. Hello, Dr. Omar.
Hello, Professor Ayman.
And now I am honored to welcome our great speakers, Professor Alvaro Orrego from Chile, Professor Ufuk Demirklik from Turkey, and Professor Ahmed Hussein from Egypt. Also,
hello, Dr. Ayman. It's a pleasure.
Thank you.
Yes.
And also, I am honored to welcome Professor Ahmet Korsat Buzkart from Turkey, Dr. Harnader Singh Bedi from India, Dr. Ashish from India, for joining us. And also, I would like to welcome Dr. Mahmoud Salah from Saudi Arabia. I welcome you all. And now, please allow me to introduce my first speaker, Professor Ufuk Demirklik. He's a senior professor of vascular surgery in Akrab Dam Hospital and Levin Hospital in Turkey. And he was the commander of medical service in Turkey and the dean and professor of vascular surgery in Golani University in Ankara. And now he is going to discuss with us the efficacy and the result of thermocoagulation, TC3000, in treatment of telangiectasia. 15 years experience as a single center. Please, Professor Demirklik.
Okay. Thank you very much, Dr. Aymar and Dr. Ömer Faruk. I share my slides now. Okay. I think it's okay.
Yes,
Dr. Ayman, do you see my slides?
Yes,
Okay.
it's okay. Yeah.
Yes. First of all, I want to thank you all of this organization, all of my friends, and then I listen all of the webinars until this time. And do you hear me?
Yes, it's crystal clear, sir.
Yes. I think problem okay. Yes, share screen again. Yes, now it's okay, I think. Yes, thank you very much. And I begin all of the lecturer and the panelists tonight. I don't have any potential conflict of interest. And as you know that the new CEAP classification, the CEAP1 is the telangiectasias or the reticular veins. And this CEAP classification defines the telangiectasia as a confluence of dilated intradermal venous less than 1 millimeter calibre. And the synonyms include the spider veins, hyphen webs, thread veins, sunburst veins, and satellite veins, and the venous flares. And telangiectasia are reported to be more common in women, and the onset is commonly associated with the hormonal changes of menarche. So risk factors include family history, occupation, prolonged sitting and standing, pregnancy, local trauma, obesity, low fiber diet, physical inactivity, smoking, ethnicity, and hormonal treatments. And the most common age for presentation of the telangiectasias and reticular veins is between the 30 and the 50 years. And mostly they are in the upper calf than the lower calf. They were particularly concentrated on the posterior aspect of the upper calf and tight and in the popliteal fossa. The presence of the telangiectasis may be associated with the insufficiency of major venous system. Approximately 50 to 62% of the insufficient perforating veins are found in the presence of telangiectasias. Lateral tight telangiectasias, were associated with both incompetent reticular and perforator veins. Obese and overweight patients were associated with a higher frequency of incompetent perforator veins along with reticular veins of larger diameters. When compared to the trunk varicosities, treatment of these small reticular and the telangiectasic varicosities is more complicated for both patients and the doctors and takes more time. Although these type of lesions cause leg discomfort, itching, restless leg, cramps, itching, swelling, tingling, pain and feeling of heaviness and tightness in the leg, they mostly appear as a cosmetic problem in young ladies. Often, women are concerned with the cosmetic appearance of the spider veins. And I want to say something about the aesthetic phlebology. All of us know that it is based on the relieving patients' complaints while satisfying their cosmetic expectation. And mostly there is no incision, no scars. And the ultimate goal of the aesthetic phlebology is to obtain the best possible improvement in the appearance of the undesired veins. And although these type of, often women are concerned with the cosmetic appearance of spider veins, self-esteem and social behavior can be affected because of the emotional distress related to the appearance of the visible leg veins. Therefore, it is sometimes very demanding to satisfy the expectations of this group of patients. Due to these difficulties in the treatment of these lesions, lots of treatment options have been used so far. And most of the patient expectation is best cosmetic results. And in the specific features of the patients with cosmetic issues, they have high expectations and they pay money for the treatment. So they think they have the right to question each details, and they have low tolerance to poor results and very low tolerance to side effects. And mostly they are tendency to prosecute if things go wrong, like the skin necrosis ulcerations. And before the intervention, inform the patient meticulously and correctly. And in the aesthetic phlebology, the photographic documentation before the treatment and after the treatment is the most important point. And the phlebologists, we have to watch our words. And we should avoid the, don't worry, all these veins will disappear. I guarantee the treatment will ensure an eraser effect on your legs. You can see certain cosmetic results immediately after therapy session. Your undesired veins will never reappear. But mostly we say our decision and then our inspection and then our results. The appearance will improve profoundly and the rate of the reappearance will be quite low, like this. Treatment methods for the CEAP patients, CEAP1 patients, is the gold standard is the sclerotherapy. And there is the other modalities like the intense pulse lights, transdermal laser, and there is a very good lecture in here 2 or 3 weeks before the basics of the laser is a very good lecture. And transdermal radiofrequency and the rising star is the cryo-laser, cryo-sclerotherapy. Now tonight, my topic is our experience in the thermocoagulation, radiofrequency ablation treatment. Thermoregulation is of the radiofrequency energy method is a technique for treatment of telangiectasis of reticular veins. The method is based on the production of high frequency waves, dirt megahertz, transmitted through a thin insulated needle, causing thermal damage in the veins. Thermocoagulation method is one of the alternative modalities that have been used for the treatment of the telangiectasis that cannot be treated by the sclerotherapy. And we use this therapy for more than 15 years. When it is applied on a lesion, it causes 70 degrees Celsius temperature inside the treated vessel. As a result, plasma proteins are coagulated and the parietal structures are destroyed. With this mechanism, the system is completely different from the electrocoagulation. Thermocoagulation has advantages such as immediate disappearance of veins, no allergic manifestations, and no necrosis, and applicability to all skin types. It is also popularly known as poor man lesion or called cautery. You see the difference of the electrocoagulation and the thermocoagulation. And in the lesions from the thermocoagulation are influenced by the power of the wave emitted, the duration of the application of the wave, the modulation of the wave. I want to say some things here about the telangiectatic method, because it is very important to treat by the microsclerotherapy and also the transdermal laser, IPL, or the TC thermocoagulation system. We all know that the telangiectatic method is considered a major cosmetic complication after the venous interventions, mostly the sclerotherapy. The etiology is unknown. It occurs more frequently in women. Various risk factors such as a family history of the telangiectasis, obesity, excessive exogenous female hormones have been implicated. However, telangiectatic method also occur in the absence of the venous disease and in patients with no previous venous interventions. These are the hypersensitivity, such as the eczema, hives, high fever, and rhinitis, is a significant risk factors associated with telangiectatic method, perhaps reflecting that mast cell activation and also the associated bleeding tendencies, easy bruising, recurrent epistaxis, despite having normal platelet function and the coagulation profile, play an etiological role in the pathogenesis of the TM. The use of oral contraceptives, hormone replacement treatments, non-steroid anti-inflammatory drugs, fish oil, and vitamin E don't have any association with the telangiectatic method. I want to say about the personal experience. Scientific evidence on the efficacy of therapy, however, should always be combined with the physician's clinical experience and the patient's preference to select the best possible treatment of each patient. The aim of our study is to evaluate the efficacy of the thermocoagulation method for the treatment of telangiectasia. Between the April 24 and the January 2020, 12,560 patients treated with the sclerotherapy and the TC3000 thermocoagulation device for the treatment of the reticular and the telangiectatic varicosities. 7,081 patients were solely treated with the thermocoagulation for telangiectatic varicosities. Totally, 37,467 lesions of cases were treated. And the telangiectatic lesions divided into 4 groups: linear, spider, arboreal, and the papillary telangiectasis. You see the demographic and the procedure-related data in the slide. Most of the patients in the telangiectatic, solely telangiectatic group is the female group, and then these are the 65-93. And the mean number of the pulses per session is approximately 800 to 900. Duration of the procedure is the approximately 20 minutes to 30 minutes. And the mean applied power is the 6.4, and the patient follow-up is the 12 months. While using this treatment, you set up the device in the screen of the device. And then this device has the 3 parts: generator and the handpiece. This has the insulated needle and the foot pitch. And you see how to set up this device, the power, the duration of the impulse, and the duration of the time, and the pulse number. There is 7 golden rules. These are the insert the needle perpendicular to the skin. It is very important. And the zone to be treated must be horizontal. And it is better to use a magnifying glass to avoid inserting the needle outside of the vessel. Clean the needle regularly with the sterile compress. Pulse every 2 or 3 millim. Work at a very superficial level and use the appropriate diameter ballet needles. And lesser and longer distances are not approved. And we use the needles, mostly our needles, you see the trademarks, the original is the ballet, and then the key 3I and the key 6I. These are our routine needles, and then in which lesions, which needles we chose, you see in the slides. We have to have a behavior before begin the treatment. Every time before sending the pulse, we must find the correct needle position by pressing on the verticosity with the needle until a small thread of the verticosity disappears, like here. Confirming that you are properly positioned on the verticosity, the gentle pressure to the needle should make the verticosity disappear before giving the energy, radiofrequency energy. At this moment, insert the needle very gently, steer the superficial, and send the pulse. And after this, we verify the effectiveness of our treatment. We pull the skin well after the treatment with our both hands to see using the magnifier that the verticosity has disappeared. If the pulse is too lateral, the verticosity will reappear. Disappearance in itself is not sufficient conditions because of the heat, it is masked by the edema for the success of the treatment, but it is a necessary condition. On the day 7, for even day 14, 2 weeks later, repeat the inspection. The space between the pulses should be pink and empty, indicating the disappearance of the verticosity. You see here 3 videos of the treatment. It is very easy, and then we use the topical antiseptics before this treatment. These are the white antiseptics, not colored, like the dermal wound cleaner, Oseptin, Octonicept, like this. And patients were positioned whether supine or prone according to the place of the treated lesion in order to have better vision. With the magnifying glasses were used to increase the precision of the needle. And this is the other, I think this is the other one, and it's the complex one, the spider, like the spider one. The most important factor in the treatment success, as I say before, the needle size is very important. You choose the correct needle size and the energy level and the duration. By giving an example, this situation can be understood more precisely. If you choose an inappropriate needle size, for example, the bigger needle, KI6, for an smaller than the 0.1 millimeter lesion, even you apply the energy just over the lesion correctly, since the needle size is bigger than the lesion, applied energy may cause damage to surrounding tissues. In occasion just opposite of this example, bigger lesion, small needle, insufficient energy may cause treatment failure. Furthermore, it is also of critical importance to see the vanishing of the lesion before applying the energy, even in combination of the right needle size and energy. By this confirmation method, paravascular application of the energy is avoided. All these treatment options optimized can be achieved by the experience and meticulous application. For lesions, especially over patellar and lateral tight area, since these areas are prone to cellulitis and edema, target treatment success may not be reached. In order to increase the success in these areas, second and third applications may be required. After the procedure, we mostly use the topical ice packs and apply the treated area. Patients were advised to continue to their daily social activities. There is no limitation for sunbath, like the laser treatment. And patients were seen on the 7 days of the treatment and then weekly until the complete recovery course. During the follow-up period, second and third treatments were performed for the residual lesions. And some of these gels, hydrocolloid gels, Flemigel, Medigel, like this kind of, one of is from the Belgium and one of from the Germany, is very efficient after this treatment to hydrate the skin. If we control our evaluation after the treatment, there is the instantaneous disappearance of the vertigo with the appearance of an erythematous microedema. Lesion become flushed and swollen immediately after the radiofrequency therapy. These new lesions are called areoles. In the day 7, 1 week later, appearance of the very fine microscopes corresponding to the pulse points, and the areoles vanished and left their places to crust. And 1 month later, there is the total disappearance. Approximately 2 and 8 weeks, these crusts are peeled spontaneously and completely recovered. Sometimes there is abnormal evaluation of the treatment because the disappearance of edema followed by the reappearance of the verticosity over the days and the follow-up time. The verticosity in reality has not been treated correctly and the edema masked the results. Sometimes the needles pigmentation, needle points pigmentation, but they are always disappears. And transparent appearance of the skin, we think that the pulse is very superficial, too superficial. And dotted appearance, some of the vertices were correctly treated. We wait 1 month and then they treat again the second time, the remaining part. How to avoid this problem? As I said before that, if the verticosity is small caliber, increase the power 100% to be sure of destroying it. If the verticosity has a larger diameter, increase the power and the duration of the emission to 0.8. And if we see the pigmentation, this is sometimes not using the insulated needles, and then they insert 1 millimeter under the skin before sending the pulse. Most of this pigmentation reduces spontaneously in a few weeks, and it always disappears over the following methods. And sometimes we use some creams. This is like the HIERARCHICAL, the pigmentation creams, and the other same creams, or this kind of formula. There is a few contraindication. This is to the needle, nickel, and pacemaker if the patient has the pacemaker, and then the cutaneous infection, which the area we are treated. If we look at the advantages of the thermocoagulation, this is very easy and instantaneous disappearance. Allergy is exceptional, no durable pigmentation, no necrosis. Speed of the treatment is maximum 30 minutes for 500 to 1000 pulses in a single season. Highly effective on all type of the telangiectasias, especially in the linear types, in all locations, on zone inacceptable for microsclerosis, on zones of the ankle, and can be used all types of the skins. As a result, we evaluate our patients in 5 improvement levels. Improvement levels in linear telangiectasia group is very high. 91% is the level 5. Spider, arborizite telangiectasia, and bluish purple small reticular vertices, this improvement ratio was approximately 65 in the level 3. And the 40% of our such cases needed the second, and the 20% of our patients needed the third application of the thermocoagulation. After additional interventions that were performed within the 3 to 4 weeks intervals, mean recovery levels, all of our patients is the 4. As you see in the slides, the recovery levels, the level 4 is the 75 to 90, level 5 is the more than 90%. And you see this graphic figure, the linear type is in the level 5, and the other spiders and the arborzyte and the papillary types in the level 4 mostly. And according to the location, if we look the results is ankle and the foot area is approximately in the 90%. And then the result is in the anterior tight, antilateral tight, antimedial tight is approximately 70%. So there is some cases, these are the before, these are the telangiectasias, and after the very early period, this thermocoagulation treatment, and see the crust is the very tiny, very small, and then after the approximately 3 months is this photo. And then the case 2, this is the lateral upper tight in this area, and then these are the areolas, the edema in the early period, and then the crust, you see the crust in 1 week later, and approximately 3 months later, the result is like this. There is a few complications, but there were no systemic and local procedure-related complications in of the patients. No ecchymosis, no discoloration, and the inflammation were seen. In only 55 patients, because of they inform us that they has the nickel metal allergies, we use the golden needles, but mostly the patients, we standard use the nickel needles. And then the no allergic reaction except the needle, there is no allergy due to the procedure. And then this is the Dr. Whiteley book, Phlebology, Venous Surgery, Volume 1. In this book, there is the chapter. Chapter is writing from the Dr. Attila Szabo, treating veins with monopolar radiofrequency experience. And then they make this experience in the 2011 to 2013. They performed 1,500 treatments, and especially they use a small group in the face. Unfortunately, we couldn't make any face treatment, and then their results is the same as our groups. And then in the lower limb, they totally the results is the 82 average to treat these patients. And our treatment first, we also learned from the Dr. Jean-Marc Chardonnay in the 24 from the France. He first used this system from the Belgium trademark, and they have the cases. But I think this part is our group in which we presented in the 2015 in the Cherry Cross, our first 5,000 cases. I think this is misciting. And also there is some historical usage of the radiofrequency energy. Mostly the dermatocosmetic, the dermatologist uses this energy in the face and the other parts of the body, and also removal telangiectasias. And there is a interesting study. This is the comparison of the sclerotherapy, laser, and the radio wave coagulation in treatment of the lower extremity telangiectasias. This is a small group, but they compare. And also they said, as I say in my beginning of the lecture, the gold standard is the sclerotherapy and then the laser. And they said that the radio wave coagulation, transdermal thermocoagulation treatment, the good result is after the 3 months later. And in their group, all of the therapies is successful, and their results is different from especially for the pain. The pain is the smaller in the sclerotherapy group, more in the TCU group, but it is not same as our group. And also this is the last 5 years, there is a study, a novel approach for the treatment of the spider veins. This is the, I want to say some things because of these results. They especially said that after this treatment, the result is very good in the 30 patients, small group. Half of them, the results of the treatment is very high, approximately 14 patients. And then if we compare the efficiency, all of these 3 groups, the efficacy is the same in the 50 to 70% of the patients in one pass, but the cost is the cheaper in the RF treatment if we compare to the laser treatment, and there is no any complication in the RF group also. Oh.
Great.
Sorry. I have a little slice. I have a mistake. I turn again my screen again. Yes, sorry. I'm very sorry because of the slides. And there is an interesting another literature. This is like the hybrid treatment. They combine the diode laser and the radiofrequency energies, ELOS treatment. And they also use the both energies, diode laser and radiofrequency energy, and they have the greater results. Is the more than the 75 and nearly the 80%. Why yes, this is here. When I want to discuss, you see that taking into the consideration to all aspects of aesthetic phlebology, such as laser, hybrid, clocks, they are all have the better results presented in the literature, especially the last 5 years, the clocks is the more popular. These techniques couldn't have the worldwide usage since they are expensive treatment options. All of the devices altogether is very high costs. But if we compare to the thermocoagulation with the lowest danger, trace the same symptoms as microsclerosis and the laser therapy, but the superior results with acceptable cost effectiveness. This therapy has been used for us and the other groups since 15 years. We have observed very rare dissatisfaction of our patients because approximately all of our patients are the women, but no incompatibility in the follow-up patients. And secondary effects are virtually non-existent if we follow the 7 golden rules. Failures are very rare. In a conclusion, thermocoagulation is a user-friendly, simple method and can be applied in a big pulse numbers according to the patients and the doctor patients. It can safely be used in the treatment of the telangiectasia disease that cannot be treated with the microsclerotherapy. And if we think that all lesions of the CEAP class can be found in our patient legs, in order to provide a complete treatment, all treatment options can be in our treatment spectrum. And all of them must be used when they are indicated. When compared to other treatment modalities, TC-RF energy is a user-friendly option and has some advantages, as I said before. It can be applied all skin types, no need for sun protection, and does not cause skin necrosis or serious pigmentation disorders. It can safely be used in the treatment of small varicosities that cannot be treated with the microsclerotherapy. Understanding the treatment of telangiectasia process and establishing realistic expectation with the patients will elevate anxiety and facilitate with a positive treatment experience. As this is my take-home message, we all, I think, agree patients with cosmetic issues search for professionals at the cosmetic when practice. And it is very important to the photographic documentation, especially for the show our results before and after. I think I finished my lecture very quickly. Thank you very much for all attendees.
Thank you very much, Dr. Ofok. It was a very nice and clear presentation. Now I think we have some time for discussion from the panel. First, I would like to welcome Professor Suat Dugansi from Turkey, Professor Victor Kanatov from Paraguay, Dr. Armando Lobato from Brazil, Dr. Sergio Giannisi from Italy, and Professor Mark Wheatley from United Kingdom, and dear Professor Mahmoud Salah from Saudi Arabia. I think you have the honor to have you all with us in this great webinar, and I will start the discussion. Let me ask Dr. Buscart, what do you think about treating telangiectasia? Would you prefer using RF or laser or sclerotherapy for treating telangiectasia? Professor Buscart?
Yes. In Turkey, Ufuk was the pioneer of this kind of treatment. He learned us first, he got experience, then he taught us how to do. Actually, I also started to use that system for a while. I bought the devices, but I don't know why I couldn't get satisfactory results as Ufuk did. Maybe he did harder, maybe he was more patient. So I couldn't get very good results as Ufuk did. Then I totally converted to laser, transcutaneous laser, and microsclerotherapy. Then currently I'm using a lot of clocks for the treatment. So currently I'm not using thermocoagulation for the treatment for the spider veins telangiectasia. But you know, in good hands, in experienced hand like Ufuk, it's a great procedure. But currently I'm not using anymore.
Thank you. Dr. Mark Wheatley, what's your impression about thermocoagulation for treating telangiectasia?
I very much liked that talk. I thought it was very, very interesting. Our own personal experiences, we tend to, exactly as Dr. Ufuk said, we treat the underlying veins first with foam sclerotherapy or sclerotherapy, and often that takes everything away. We use microsclerotherapy for anything on the surface, and I'm quite interested in looking at claques. We do have some cases where we use the thermocoagulation, mainly though it is for the face and above the diaphragm. We don't tend to use it too much for the lower leg. I think exactly as Dr. Buscart has just said is absolutely correct, that it is a very user-dependent technique, and I think you really need to have the skills. One of my questions I just put in is whether you keep when you're doing it so fast, if you keep the power on as you go through the skin, there's always the question is, are you making the skin opaque and not seeing the vein? And it really is about a depth perception. I think there's a huge amount of sort of personal skill needed to get these good results.
I agree for that. Sergio.
Hello, everybody.
I think the mic might be not on with Ayman. So if you tell us your opinion, Sergio, with the great lecture of Ufuk and using thermocoagulation.
Sure, indeed, it was a great talk. I really appreciated that. I would be curious on the cost effectiveness analysis of this, because as we know, we can treat these veins in many different ways. Of course, we have contradictory indications if you look at the guidelines from all around the world on this. So a good point, I think, would be understanding if it is valuable for a cost-effective standpoint to have a device like this in a phlebology office. And I'd like to have a comment on the cost of this? Because we know that we can treat these veins in many different ways. We know the effect of transdermal lasers in this. So do we really need this device, and could be the cost effectiveness an answer to that?
Okay, Professor Ofo.
Yes, thank you very much for all comments. First of all, Dr. Kürşat and then Dr. Whiteley, I want to give my answer. Yes, it is very important when we begin to treat the lesions. Our needle is just on the lesion, and then the very small force in the telangiectasic vessels see the absence of the blood, and then they give the energy, and then this part of the needle is not insulated. The other part of the needle is insulated, and then we give approximately very small 1 millimeter in the treatment zone, and then these thermal effects affected the telangiectasia. My experience, my treatment is the microcircular therapy. I choose my strategy. First, I perform the microcircular therapy, and then I wait the healing of the lesion. And if there is no disappearance of the telangiectasia, that time I added the thermocoagulation mostly, like different than the CLACS. In the CLACS, the first laser and then the circular therapy. My strategy is the first circular therapy and then the TC. But you know that there is the young ladies. You see our mean age. Most of the young ladies. And then they have the solely telangiectasia. It's the whole, some part of their legs. And in that time, I perform this solely telangiectasia directly to the TC. And then there is no problem if in the first treatment, the result is not good. We make again, approximately 3 weeks later. And then make again, like this. We treat these lesions. And Sergio, yes, in the transdermal laser, yes, last 5 years, the hybrid therapies, and then the dual waves, and all of this kind of lasers treatments has the very good results. But I want to say again, the cost of this kind of laser suite is very high, and then if the results is approximately the same, why don't we choose the cheaper one? Because you need only needle and then the only device, and then the device in the US market, and then they have the FDA, and also in the European market, and it's very acceptable prices, not as much as the laser devices and the laser equipment. That's the cooler and then the other equipments.
Okay, that's great. Let me ask Professor Lowell Kapnick from the United States. Welcome, sir, to the panel.
Thank you.
Nice.
I've had experience with this device over a number of years. And I think that there are 3 locations that I think are effective. One is the face. And then, as you pointed out, the micro vessels that I can't get my needle into, and the hemangiomas, I think, work well. I had very much difficulty, as Dr. Boskirk said, with larger veins, and vessels may be my technique. But right now, most of the time I'm using sclerotherapy, and then occasionally I'll supplement it with this technique. In terms of laser and CLACS, there seems to be a lot of press with CLACS. It's not widely accepted in the United States, although it is a good procedure. I've seen it performed. It is expensive to buy a laser, but over the period of time, you probably will be able to pay for it with a number of treatments and effective treatments. But I do think that you need both sclerotherapy, and some other device to help you achieve the results that you should be getting and that the patients would like.
Great, you have a point, sir. I have a question for Dr. Ofok. What is the situation if you have a reticular vein connecting to this telangiectasia? How do you deal with that?
Yes, if we use the when we were and see the feeding veins and then the reticular veins, also we routinely make our patients, especially in the C1 mapping of the Doppler ultrasound. We have to treat these reticular veins with the microcirculatory. In my country, there is only the 0.5 of the polydecanol, but we delayed half, and then we use the 0.25, this kind of the reticular varicose lesions. This device is also had the effect of this size of the vessels, but this result is not good. Maybe Kürşat is right, because if you don't choose the correct lesions, very small telangiectasis, approximately smaller than the 0.3, 0.1, 0.2, it is very good. But in the bigger, the result is not good, and then the recovery time is long. So I routinely perform with the microcirculatory to 32 gauge needles, and then the 0.5 or half cyclorhizin agent polydecanol.
Great. I think now we have to listen to the situation in India. Dr. Bedi, what's your plan in treating telangiectasia?
Hi. Thank you, Dr. Ofok. That was a lovely presentation.
Please, can you raise your voice a little bit?
We so far have been using microsclerotherapy, and I have a few questions regarding your technique. One is, if you want to use it on the face, do you use a different needle, or there's a similar needle? And two is, do you need to use any topical local anesthesia, like a local anesthesia cream? So that's my question for you.
Yes, normally we don't use any topical local anesthetic like the amla, lidocaine. But if the patient has the problem for the pain problems or the psychological problem, we use. And when we use the local topical anesthetic, we compare that the energy is different than the with the topic after the topical local anesthesia and then the directly. There is no difference. We use the same energy, but if after the local anesthesia we clean again with the dermal wound cleaner this lesion area, and the needle is different. There is the two kind of needle. One is the K3I, and then the one is the K5, K6I. These sizes is different. In the face, is mostly the orbital area, the bigger one. The dermatologists used to K6I, the bigger one. But in the other part, telangiectasis, they use the small needles. I use in the leg small one in the telangiectasis. In reticular ones, maybe you try to big needles.
Great.
Thank you.
Let's go to Brazil. Dr. Armando Lobato, do you have such experience in treating this telangiectasia, sir?
Yes, we do have, but we do not have with anticoagulation. I think that it's a very, very good option for in the upper part of the body, in principle in the face. We do use for telangiectasis in Brazil, the majority of the cases, it's a sclerotherapy because it's a cheaper treatment. Some places already use a CLAX, a mix between sclerotherapy and laser regarding the sclerotherapy, the majority of the case here use hypertonic glucose. That's in the majority of the case, but polydocanol also in some case you can use, but we have no experience, only by literature about anticoagulation therapy.
Great, that crystal clear. Back to Turkey, and let's ask Swat Tugansi. Dr. Swat, do you share the same photocoagulation, or do you prefer using different techniques?
Dr. Ayman Fakri, thank you also for including me to the panel. As also Dr. Bozkurt explained, Dr. Ufuk is especially the pioneer in using thermocoagulation in Turkey. So he taught this technique to almost all of us, but this technique is mostly used in the private practice. So I am working in the state hospital, so we don't have a chance to use this one, but I know very well from his private practice and from his lectures also in Turkey, if you use it in combination with sclerotherapy, and if you use it for the telangiectasis after the sclerotherapy, it's an effective therapy. But of course, in all of the techniques, you should be, I think, a dedicated person to perform such aesthetic cosmetic techniques. This is what can I tell you.
Great. Let us see the situation in Saudi Arabia. Dr. Mahmoud Salah, do you have a lot of telangiectasia patients in Saudi?
Yes, actually we have, and I have some experience in this radiofrequency ablation machine for the last like 10 years or 12 years. And we are getting very good results with it. We use local anesthesia, topical, this EMLA cream 15 minutes before as a routine, because most of them are refined ladies, so the pain threshold may be different. But my question, first, I enjoyed the talk very much. Thank you very much. And my question, there are some veins that you can do both, either microsclerotherapy or the radiofrequency ablation. What would you prefer for such veins?
Yes, thank you very much. I want to say we used both techniques together. First the microsclerotherapy and then the TC thermocoagulation, but we compared sometimes in the suitable lesions, one leg and then the microsclerotherapy with the low dose polydecanol, and then the one leg the thermocoagulation. But especially, as I said before, the arborzyte group, and then especially for the telangiectatic, if we give the although the small dosage of the sclerosing agents, there is the very quickly hyperemia in the skin, and then the recovery time is, the healing time is very long. But if we perform this kind of the telangiectatic metting with the TC, the result is very good because there is no any side effects, there is no skin problems. And there is, and as I said before, there is no pigmentation, long-lasting pigmentation. I offer very small diameter telangiectasia in the lower part of the body, especially for the ankle, foot, skins, you know, is very thin, and then the subcutaneous tissues are not more in that area. If we use, there is the contraindication to use the small amount of or small dosage of the sclerotherapy in that area. There is the skin ulcer problems in that area. So when I use this kind of lesions, telangiectasias or the small reticular varus spider veins in that area, the result is very good.
Thank you very much.
Before we go to the Klaxman, I would like to have a comment from Ashish from India.
Thank you, sir. Thank you, Dr. Ufuk. That was indeed a very lucid presentation and a very exhaustive one. honestly, it would be really improper on my part to, compare thermocoagulation and CLACS, because that is what I do back in India. Though there are one or two features which probably where CLACS differs from thermocoagulation. One is use of augmented reality to find out the feeder veins and treat them. Because I saw in one of your slides the percentage of arborized telangiectasias getting cured was 65%,
Yes.
if I'm not mistaken. So CLACS would basically, the vein viewer, the augmented reality, would help to identify the feeder veins. And the second point which I would like to make is in CLACS we can go even up to 3 millimeter veins. We can treat reticular veins up to 3 millimeter. In fact, few days back, Professor Kanata mentioned he treats even veins up to 4 millimeter. So that is another difference which I noticed. Though I would like to again thank you for highlighting the 2 points. One is the slide on the choice of words in aesthetic phlebology, which I feel is very important. And second one is the photo documentation. That is a very, very important aspect of aesthetic phlebology. So thank you, Dr. Ofuk.
Thank you.
Great. Now we have to listen to the last comment from Victor Kanata from Paraguay.
Okay, it was a very nice presentation. My question are 2 points. First of all, I thought that he stick the needle too many times for the patients. Does he numb the skin or just is go over with the needle from the telangiectasia? The second point is, in my area, in my place of work, we have high level of people who, after they saw the needle, they just faint sometimes. I'm so afraid for the pain that we can give it after the procedure. That is my complaint. And my question, and there is a third question. If you leave so many openings over the vein, you will have a lot of bleeding after this. How much is the amount of bleeding that he has? But it was an excellent presentation. With CLACS, we have very good results over here in Paraguay. And also we have sclerotherapy plus laser working very nice and very well. But I would like to have these 3 questions answered before we ask for the next presentation, okay?
I want to say some things about your last question, that there is no bleeding, because when we put the needle on the site of the lesion, we press, we don't cut. We only give the pressure, very, very, very little pressure, and at the same time, synchronously, we give the energy. So the name thermocoagulation, and it's the thermocoagulate the blood in this kind of telangiectasia, red telangiectasia and the venoulectasia, like this. There is no bleeding, and we changed in the treatment period more than 2 or 3 times the needle, and there is no problem using the one needle, approximately 1 session, but sometimes there is the damage in the needle, and then because of the insulate part is very important, so we change the needle in every session. And in the pain, because of the needle, it's, yes, you are right. In the first trial, when we begin to the first time the treatment, we explain all of the things, the ladies or our patients, and first we make approximately 50 to 100 trials, demo. And then they show that there is and we see that this is the very small insect bite. And in our first experience, in the beginning, 2004, first we applied the cold package in the telangiectasias because to prevent the pain, and then we applied the energy. But we saw that because of the cold, most of the telangiectasic lesions disappear. And also the patients, if the room, treating room is cold, and then because of they are the anxious and they afraid in the beginning, they are was a constrictive. So we don't use before the cold. We only use after to prevent the eye roll edema, very small portion.
Great. I thank the panel, and I will leave the mic for Omar because I think many questions from attendees. It's yours, Omar.
Okay, thank you. Yeah, thank you very much, Professor Ayman. I will take few of the questions that we have for Professor Ufuk. The first question: thank you, Professor Ufuk, for your great lecture. Anything regarding the result of radiofrequency or laser treatment of telangiectasia compared to sclerotherapy, which I agree to treat reticular veins? He basically say, what is the big advantage to use thermotherapy for telangiectasia?
Yes, as I say before, it's the well-known. If you look the literature, the microsclerotherapy is the main therapy. All kind of the telangiectasia, venulectasia, and then the smaller reticular spider veins. And we compare, or I also try some of the laser, idiot laser in my practice, and 3 different trademark laser in the transcutant, but I have some complications more than my experience in the thermocoagulation. Maybe this is my chance using this kind of the transdermal laser, but I don't have more experience in the NDIAC laser. I have the diode laser and the shorter waves. Maybe our protocol is not good. So if we compare the 3 of them, as I say my conclusion, we have to all kind of them. Because if we compare the laser, not only one wavelength is the suitable all kind of the lesions in the legs, lower part of our body. Sometimes it's the oxyhemoglobin, and then the color is like the blue ones, like the venulectasias. And then some wavelength is in the deeper, like the NDIAC in the CLAX therapy. I think we need to use all of them and personal experience, and then choose the treatment to the patient's lesions.
That's very good. Yes,
is like this.
Yeah, I think the opinion of Professor Loyal Kabnik that it is an ideal situation if you have small facial veins. I totally agree with this. We have another question.
I'm also agree, because we all know that there is no hydrostatic pressure in the face upper our heart, and then in that part, after the treatment of the thermocoagulation, the smaller, like in the border of the nose, in this kind of the telangiectasia, this result is very, very good. And then there is no limitation to the sun protective after this treatment. If you use the laser in the face, the patient have to be protected from the sun.
Yes, yes. Another very important question from Professor Mark Whiteley. He said it appears that you are using heat when you penetrate the skin. As the video shows, the skin goes white. Are you inserting the needle while the power is on? I have a similar system. You puncture the skin without the power on. You only put the power on when you are touching the small vein. Is that correct?
Some of your voices, yes, I don't hear the whole of your sentences because it stops. As I understand that the skin type of our patients, you know that our country is the most of the every kind of the skin color in our country, but most of them is in the first and the second.
I will say the question again. I will say the question again. Professor Mike Whiteley is asking you if you put the power on before you insert the needle into the skin.
No, no.
Exactly.
not
You
power
put it
on.
in because the power is the
Yes.
power switch. So if you actually put the power on, you cause coagulum in the skin, so it doesn't move. You don't penetrate.
Yes, exactly.
Yeah. So you have to penetrate
Yes.
the skin first, and then you do shooting with your pedal.
This is very, the needle is is very sharp, very
Yes.
thin and sharp, the tip of the needle, and you put directly the perpendicular to the right angle to the lesion, and then first you saw that you are on the telangiectasia or the lesion, and then give the energy. Then you at the same time synchronize the foot switch of the device and give the energy, and after you begin, you give the direct the pulses, continue like 1, 2, 3, 4, like this, continue.
Okay, I will take the final question from one of the attendants who raised his hand. His name is Dr. Muhammad Al-Mashaddari. If we can open his mic, Dr. Muhammad can introduce himself and can ask his question. Dr. Muhammad Al-Mashaddari. Yes, you can ask your question, Dr. Muhammad. That's it. No, it's locked again. Yeah. Now we can, if you can introduce yourself and ask your question, Dr. Muhammad.
Sorry, can you hear me?
Yes, we hear you.
Yes, we can hear you now.
Yeah, okay. I'm Dr. Muhammad. I am cardiovascular surgeon.
Okay, ask your question.
Yeah, my question is that which is better, to use sclerotherapy or radiofrequency or laser?
The answer
because
is
I have
very
experience with all these types.
Yes, the answer is very easy. First, we have to try the microsclerotherapy. Low dosage, low concentration, and suitable equipment, suitable injector with the sclerotherapy. And then the very small lesions, as our series, the telangiectasia, I think the thermocoagulation. But as the bigger size of the, like the reticular, like in the CLACS, both of the hybrid treatment, I think, the best result.
Okay, thank you very much. I think with that we have an active participation, and the mic is back to you again, Professor Ayman.
Thank you, Omar. Thank you, Dr. Demirklik. It was a very nice presentation and very nice interactive discussions. Now I am honored to introduce my dear friend, Dr. Alvaro Orrego from Chile. Dr. Alvaro is a senior vascular consultant and fellow of American College of Surgeons. He's a president of Children Phlebology and Lymphology Foundation, and previous president of Children Phlebology and Lymphology Society. He's a distinguished member of American Venous Forum and member of American Venous Forum Guidelines Committee and American Venous Forum International Committee. Dr. Alvaro now is going to talk about leg incompetent ankle perforators treatment. Please start, Dr. Orrego.
Okay, hello, my dear colleagues. Okay. Hello, dear colleagues. My name is Alvaro Orrego. I'm a vascular surgeon. I live in Chile. It's a pleasure for me to share this time with you in this wonderful activity. I want to thank very much the organization committee for inviting me to this activity. I have no disclosures. Well, in this work, it is possible to observe that 5 to 30% of the adults have venous disease, from 63 from them, 63.9% have important clinical manifestations. And it is very important. Statistic is very important because 1.5% of the population suffer or has suffered from leg ulcers. Well, understanding anatomy and hemodynamics is very important for the best treatment of the leg, obviously, no? There is a demonstrated clinical relationship between leg perforating veins incompetence, lipodermatosclerosis, and leg ulcers, especially with distal perforating veins. It is necessary to emphasize that usually perforator veins are related with venous ulcers, depend on posterior accessory subvenous vein of the leg and drain into a tibial posterior vein. Here we have the Leonardo's vein in Argentinian literature and the relationship with tibial posterior veins through these perforator veins. No? And we have two perforator veins from the great subvenous vein to other veins, no? To other deep veins. Well, nowadays, the discussion of the origin of and drainage of perforator veins has been abandoned due to appropriate ultrasound studies define very well the problem, allowing the right therapeutic approach. In this slide, we can see different stages of leg ulcers. We can see hyperpigmentation, lipodermatosclerosis, healed leg ulcer, and active leg ulcer. Well, and here we can see the guilty, a perforator vein. This perforator vein going to tibial posterior vein. Oh, it's not possible to see the cursor. Well, we have a tributary to a perforator vein crossing the aponeurosis, and the measurement did in the aponeurosis, no? And the the tributary is draining into the perforator vein, and the perforator vein is draining to a tibial posterior vein. We can see the artery and two tibial posterior veins. Oh. Why? Excuse me, I have a little problem. No? Wait. Just a second, just a second. Okay?
Yes, yes, we can see it now. Go ahead, yes.
Okay, well, in this video, there is a perforator vein going to a tibial posterior vein. Anatomical and hemodynamical behavior description of the vessel is really important for planning our procedure. These old videos show perforator veins reflux in red. It is also possible to see the blood movement. Last means stasis usually, and it means high probability of deep venous thrombosis or perforator and branches of the and tributaries thrombosis. No, In our practice, the diameter of the perforator vein is measured at the aponeurosis, and reflux time is got by Doppler. Treatment evolution. Well, perforator veins has been a matter during the time. I remember when I was a very young vascular surgeon, we performed a lot of procedures and always with not the best results, no? But I think nowadays the evolution led us to have a very good treatments and with very, very good results. Well, many years ago, many years ago, we used to perform Linton's procedure. We did an excision of the skin and aponeurosis. At the same time, we cut off and ligated the perforator vein. Later, we did a skin graft. Here you can see the wound, and it is ready for a skin graft. Well, the recovery was very long and painful. The costs were high, and the procedure affected the functioning of the leg pump because we made an excision of the aponeurosis, no, and we made at that time a real hernia in the aponeurosis of the leg. Well, at the end of the last century, subaponeurotic endoscopic perforator surgery, CEPS, was developed by Professor Peter Glowicki. It was a very interesting approach to treating competent perforator veins with minimal invasion. And well, in this video, we can see the subaponeurotic space. We used laparoscopic devices, and well, the dissection of the perforator vein. We were clipping. First clip. Second clip. Cut off the vein. It was really interesting procedure. I enjoyed a lot. Take care with the nerve. And that's all. It was nice. Well, now we abandoned this procedure because it was easy to perform for experts, but for beginners, it was really difficult because there were some details on the technique, and if you don't do that, if you didn't that, it was really difficult to have the subaponeurotic space, and well. And the other problem was that we needed to treat the tributaries, because treating just the perforator vein is not a solution, because the venous circulation of the leg is damaged, and from deep vessels to intrafascial vessels and thermal and subdermal plexus. In this video, ultrasound-guided perforator vein puncture is seen. Please note blood reflux from the catheter, and now inserting the fiber. Fiber introduction into the perforator vein is seen in this video. Subsequently, to messen anesthesia and ending delivering energy. Here you can see the fiber, the needle doing tumescence. It is a very, very fast procedure. You need a good image, very, very high level ultrasound, and okay, delivering energy. It is very important. It is really, really important. Please note the direction of the bubbles from depth to surface. It is very important surgical detail since tumescence avoids hot bubbles going to the deep vessels. In other countries, it's very popular to describe the Cohen's sign, no? And it means bubbles going to the tibial or deep vein. And of course, it is not recommendable if you think the bubbles are have a high temperature. With a very, very good image, you can see not just the fiber, you can see the walls of the vein. Well, parameters. Wavelength, length, usually 810, 980, or 1470 nanometers. The majority of the people that perform those kind of procedures, endocclusion of perforator veins with laser or radiofrequency, well, use 980. And for diet 980 nanometers, fiber diameter, 600 microns, power, usually 8 watts, total energy 300 to 800 joules, and of course, always, yes, always tumescent anesthesia. Because if we want to have a very good result, we need to think that we need to put in contact the fiber with the wall, and because we're looking for the best result and avoiding recanalizations. No? The recanalizations are very common in those kind of patients, in those kind of treatments, because the perforator vein receives a lot of pressure because the hydrostatic pressure, no? And well, and we had a huge experience with radiofrequency too. Percutaneous thermal occlusion powered by radiofrequency of perforator vein is shown in this video. We have used the technique for a long time, at least 7 years. However, suddenly we had a high rate of recanalizations with this device. Therefore, we went back to laser. And again, we have a very high rate of occlusion. Well, here we can see the catheter. The name of the catheter is stylet. And it is a very good a device because it's semi-rigid and is really easy to insert into the perforator vein. But I don't know why, but I think the change of the owner, but suddenly we started to have a lot of recanalizations, and we noted immediately because we control our patients. We have a protocol and we control 1 week after the procedures, and we had in one moment we had 50% of recanalization, and it is impossible. It is very, very, very bad. For instance, therefore, we came back to, we went back to laser. Well, the same safety margins are used either with laser or radiofrequency styled, at least half centimeters distance from the skin as well as from deep veins is required. This picture was made with a styled radiofrequency catheter, but the the safety margins are the same. Well, sorry, but I need to, because there are a lot of literature about perforating veins, the treatment, the results, but is incredible. We're reading one of my favorite guidelines, the American Venous Forum guidelines of the management of incompetent perforating veins. And please, let me show the grade of recommendation and the grade of evidence, please. Just see the numbers. Well, but for open surgical treatment of incompetent pathologic perforating veins located beneath a healed or active ulcer, we suggest against the modified open Linton procedure owing to associated morbidities. For those patients who would benefit from pathologic perforator vein ablation, we suggest treatment by percutaneous techniques over subfascial endoscopic perforator surgery. In patient with a venous leg ulcer and incompetent superficial veins that have reflux to the ulcer bed, in addition to pathologic perforator veins located beneath or associated with the ulcer bed, we suggest ablation of both incompetent superficial veins, very important, incompetent superficial veins, and perforator veins, in addition to standard compressive therapy to aid in ulcer healing and to prevent recurrences. In patients with skin changes and risk of venous leg ulcer, C4B, or healed venous ulcer, C5, and incompetent superficial veins that have reflux to the ulcer bed, in addition to pathologic perforating veins located beneath or associated with the healed ulcer bed, we suggest ablation of the incompetent superficial veins to prevent development or recurrence of a venous leg ulcer. Treatment of the incompetent perforating veins can be performed simultaneously or staged. In patients with isolated pathologic perforator vein located beneath or associated with the healed or active ulcer bed, regardless of the status of the deep vein, we suggest ablation of the pathologic perforating vein in addition to standard compression therapy to aid in venous ulcer healing and to prevent recurrence. Fortunately, the last. For those patients who would benefit from pathologic perforator vein ablation, we suggest treatment by percutaneous technique that include ultrasound-guided sclerotherapy or intravenous thermal ablation, radiofrequency, or laser over open venous perforator surgery to eliminate the need for incisions in areas of compromised skin. Well, I think it is the summary of our ideas of the problem, and I must absolutely agree with the majority of these recommendations of this from this guideline. But of course, I I accept that the grade of evidence is not the best, but well, it is very important to study and to read the recommendations, and of course to have a good experience and to be an expert in treating these problems. No, remember, in order to have the best solution, we need to share 3 points. No, three points. The evidence knowledge, the recommendation, the level of the recommendation, the opinion of course of the patient, and your expertise. Remember, if you are a very expert in those kind of procedures, you will have better results than the average. And well, for this reason, it's really important to study the problem, to have a point of view, and to practice, and to have a good practice, no? With those kind of procedures. Because if you don't do this seriously, probably you will have a very high rate of recanalizations and recurrence of leg ulcers. Well, our group has had experience performing open surgery, CEPs, sclerotherapy, laser, and radiofrequency. Data from our group, all data, show 4 recanalizations of 223 treated perforating veins with laser between 2011 to 2015. And well, the last idea, no? Oh, excuse me, I want to. Sorry. Well, sorry, excuse me. Just a little moment. Because well, it is really important. The most important concept is treating the venous complex, where the perforating vein is just a part. Well, thank you very much for your attention.
Thank you, Orego. It was very nice and a very good presentation as usual. Thank you, and I think it's time to get some comments and questions from the panel. I will ask Dr. Lowell Kapnick. Dr. Kapnick, as you see Dr. Orego using bare fiber in treating perforators, do you think it is safe not transmitting this energy to the deep system?
Well, first of all, I'd like to thank Dr. Orego for a very comprehensive talk. It was excellent. And yes, to your question, I think it's the standard of choice right now for laser. There was a trial that was performed here in the United States called the SECURE trial, which showed the efficacy as well as the safety in terms of that. However, there are some non-thermal devices that are now being investigated for its efficacy and safety. So I think we're on to something, but I do have a question, if I may ask Dr. Orego. Dr. Orego, after you do the ablation of the perforator, do you foam the ulcer bed, the underlying veins?
If I foam the tributaries?
Correct.
Oh yeah,
the underlying
always, because treating just the perforator vein is similar to high ligation of the saphenous vein. You need to treat the tributaries.
The second question is, yeah, go ahead.
And Dr. Kapnick, and during the last years, we saw that the reticular plexus, the dermal and subdermal reticular plexus are dilated and with reflux. And for this reason, we use a high-frequency ultrasound for finishing the treatment of the incompetence of perforator veins.
Thank you. So let me ask this question. Now that we're dealing with C6 disease, and we know that there's a significant amount of outflow obstruction, iliac vein obstruction, which one do you do first? Do you treat the superficial system, including the ablation of the truncal vein, and then the perforator, or do you go straight to the obstruction?
Oh, in my practice, I prefer to start with the leg problem, and if there is a recurrence of the leg ulcer, or the patient has is symptomatic, I go to solve the problem in the leg vein.
Thank you much for the opportunity.
Okay, great. I asked Dr. Martin Marsh from Bahrain. Welcome, Dr. Martin. Do you see in cases of perforators, Dr. Orego reported 50% recanalization using styled radiofrequency catheter. What do you think about that? Use RF or laser in treating perforators? Dr. Martin?
I think he's not on the mic. Maybe we can take a comment of another panelist. Yes, Professor Whiteley.
Hi there. You probably know we've published a lot of work on perforators over the years. And in fact, we first described the technique you've talked about tonight in 2001. We called it the TRLOP technique, the Trollope technique, which was rewritten by our colleagues 7 years later as a PAPS technique. The thing with it is the radiofrequency stellette, which we actually helped Venus to develop, and now we use laser, we use microwave, you can use any heat. But the most important thing is you have to destroy the vein wall. And the difficulty is with the radiofrequency is that the way that the instructions use were written was incorrect. So what they said is they said put it into the vein, lift it up and burn the vein, put it down, burn the vein, side and side. And what you actually do is cause a thrombus. And it's because you get the thrombus, you end up with recanalization. We ended up with very good results, which we published our 5-year results. If you put the stellette in and then push hard, so there's no blood in there. So it all comes down to the physics. It comes to whatever heat you use, don't get thrombus, and just make sure you burn the vein wall. So I think if you look at your RFA technique with a stellette, you'll probably find that you're using the usual the usual technique where you're actually doing what the company said, which was not the actual compression to get the blood out.
Well, thank you very much, Mark. We started the practice of treating perforator veins with laser, I think during 2004 with a friend of mine in Argentina. And about the stylet, we didn't have any problem because we performed tumescence, and we always had contact between the catheter and the wall of the vein, because if you just push the tissues, is not possible to have a very good compression and having the contact between the catheter and the vein wall. I think it is very important now.
Well, the tumescence is only going to give you about 5-10 millimeters of pressure, whereas if you push on it, you get about 100 millimeters of pressure or more. So you're going to get much better contact with pressure than you are going to with trying to inject tumescence. And I think, and as I say, I'm not arguing that laser is not good. In fact, I use laser all the time now. I think you're quite right. But I think the key to this is do we treat the perforators or not? I think that's more important. And although most people now accept C6 disease, I mean, we as I wrote in a transatlantic debate recently, we treat C2 disease. I think if you accept that C6 disease, you accept C4 disease. If you accept C4 disease, you accept C3 disease, and so on, because the point is this is pathological reflux. So I totally agree with you that thermoablation is the way to do it. And I think what we should also be doing is saying any pathologically refluxing perforator needs treatment this way.
Well, I absolutely agree with you about the problem of the first definition of the technique. No, I remember a video from the company, and they showed you need to put up, down, up and down, and lateral. Well, but well, I think we have the same conclusion. It's necessary to have a contact between the catheter and the wall. Well.
Okay, thank you, Mark. Now I would like to hear the comment from Dr. Sergio Genesi from Italy. Hello, Sergio.
Hi, guys. Yeah, so it's also always a very interesting topic and a nice talk from Alvaro. I'm just wondering if we are over-treating perforating veins, considering that we also published recently that the sensitivity of the outward diastolic flow longer than 500 milliseconds is actually just 14%, which means that the net flow, the vast majority of time, is actually inward, despite the fact we see an outward flow. So I like to have this group of top experts brainstorming if we have the feeling that we can still go with the traditional definition of incompetent perforating veins as an outward diastolic flow of 0.5, and if the fact that the multiple perforators we have usually have multi-truncal appearance could really have a satisfactory results with just this kind of treatment, or if a foam could be at the end of the way, the easiest way to treat this. So it's a question for Alvaro and for all the panel.
Well,
yeah, all right, great.
Absolutely agree, Sergio, absolutely agree. And it's incredible, but nowadays we have the same concept done a lot of time ago, that the indication for the treatment of incompetent perforator veins is just a measure in the aponeurosis. But well, when you study well the complex of the veins related with the perforator veins, we can see different situations. For example, a big net of tributaries going to the perforator vein, and sometimes the diameter of the perforator vein is not so big, but you have clinically a big issue, a big problem, and lipodermatosclerosis. And in other occasions, in other situations, you have a big hole in the aponeurosis and a thin tributary. I think we need, I absolutely agree, we need to redefine the concept of the perforator vein, and not just think about the perforator vein. We need to think about the whole complex, because the perforator veins are not alone. Absolutely agree, Sergio.
Thank you.
Great. Before I leave the mic to Omar, I'll ask Dr. Kanata to give his comment. Victor?
I will open up. Oh, give me a minute. I lose everything. Okay. Where is that stuff? Okay. I have two questions. The first one, how Alvaro was an excellent presentation, but my question is, you are talking about anesthesia, local anesthesia. If you give the local anesthesia, usually when I do like a laser ablation of perforators, it's impossible to find the perforator after I give the anesthesia. I just usually do the stuff which is the puncture. I'm going with the needle, a very fine needle, and then going through over the perforator with the needle. And after this, I insert my laser fiber. And then I fire. Usually I fire 1 or 2 watts. It's not too painful, and the vein disappear immediately. It's very difficult to do it and have so many tricks. How do you do with the anesthesia? Or I don't know. But my second point is like this. I would like to know also, and this is a very tricky question for my friend Mark Whiteley, what he feel about HIFU for perforators.
May I answer? Well, Victor, the technique is injecting just a pupil of local anesthesia in order to puncture the vein, the perforator vein. And when you have your catheter inside the vein and your fiber inside the vein, you perform the local tumescent anesthesia.
Okay, great. Are you ready, Omar?
Yes, I am ready, yes. Okay, we have about 11 questions and we have 3 raised hands. So I will take quickly the first question to Professor Orrego from Dr. Haidar Aslan. He said, for open venous leg ulcer, what is the optimum procedure you would advise for closing perforators?
Well,
optimum procedure.
Yeah. Oh, it's a difficult question because nowadays, for me, it's very difficult to perform. I don't want to perform open surgery because, well, first of all, never Linton's procedure, never. But sometimes you can make a little incision and to localize the perforator vein and cut off the perforator vein and ligate. The big problem with that technique, usually you have lipodermatosclerosis or hyperpigmentation, and you could have a big, you could start an ulcer. But if you don't have a laser or other or echo-guided foam, well, echo-guided foam is absolutely other matter, no? I think it is a different chapter for perforator veins, and but probably the best option is to perform a little incision to get the perforator vein and.
Okay, now the second question from Dr. Omar Al-Dahan. Is it routine that you do skin biopsy in cases where venous ulcer you want to exclude malignant margarine ulcer? Do you do routine biopsy to venous ulcer?
No, we have a protocol for asking for a biopsy, no? Yeah. In recalcitrant leg ulcers or with pigmentation or something that guide your criteria to look for a cancer or for a inflammatory disease or another etiology. Yeah, that's the idea.
Yeah, okay. Now another question from Dr. Muhammad El-Mashaddani. He said, had you got VTE and what is the percentage?
No, no, because we have a very rigid protocol with our tumescent anesthesia, and we respect the safe margins. And it is very difficult to have a DVT with those kinds of technologies now and the thermal technologies.
Okay.
Well,
Another.
with foam, I had some DVTs.
Yeah. What is your anticoagulation policy?
Yeah. Usually it's not necessary, but if the patient has a thrombotic story, I prefer to use some anticoagulation, and usually I operate on the patient anticoagulated, and I use anticoagulation in those kind of patients, usually for 1 month.
Okay, so we'll take one last.
NOAC.
Okay.
Xarelto.
We'll take one last. Yeah, we'll take one last question from Dr. Erwin Tonder, who raised his hand. If you can introduce yourself and ask your question to Professor Orego. Dr. Erwin?
Yes. Yes, can you hear me? Yes, you can hear me.
Yes,
good evening all. Hello, no, greetings from Wijnand van Gent. That's the guy I want to refer to tonight. Great presentation, Dr. Orego. And I was very glad to hear Mark Whiteley after seeing your American Venous Forum guidelines, which are outdated. Nowhere in the guidelines which have a grade 2 recommendation, which is extremely weak, and a grade C level of evidence, which is low to very low quality. These are the guidelines we are using. They're outdated. We are referring to Labropoulos criteria based on his study about the 3.5 millimeter diameter and the half-second reflex. And I was glad to hear Mark say, yes, we shouldn't be focusing only on C6, ulcerated legs, or C4, poor skin, that we're trying to access a perforating vein in. And my question is, shouldn't we update the guidelines and shouldn't we be more specific? Because I really am enjoying the discussion about giving compression, no compression. There's no mention of lead. What kind of laser fibers should you use? There are laser fibers which are cutting fibers, which are very good if they're used in safe hands. If you're inside the vein, you don't need the radial fibers. If you have radial fibers, do you use high energy levels? We had a discussion about lead the last time with Mark Whiteley. We should have this. If you're using radio frequency, it is a bit, also a bit too patient friendly. We have other techniques, the Turkish glue. I know that Kursat Buzkurt has Turkish glue. I have, hello, Kursat. I'm still waiting for the Turkish publication on using glue in perforating veins safely. I know you have some experience, but there is some concern if we don't have a good protocol, we will be treating the deep venous system. And that's where we really should be aware of, because I know that last year, in the end of 2019, that SADC had a very good presentation, which was also published in the Venous News, to make people aware that we're not just looking at hydrostatic pressure, which was mentioned earlier. We're looking at deep venous obstruction in about 50% of the cases when perforating veins are involved. And they are then, at that particular point, they're acting as a collateral. And we shouldn't be treating, and these guidelines are recommending, treat the superficial system and whatever. Really, we should be doing proper diagnostics and very carefully scrutinize the complete deep venous system before thinking about any form of strategy. And Dr. Orego, Mark Whiteley, Lowell, if you have an opinion about it, you also have an opinion about everything. Please, guys, we're here and we should modernize our approach and do a proper job for all our attendees to realize this is not just easy, just stabbing and accessing a perforating vein with blood, emptiness or not blood emptiness, whatever. But please, I'm looking forward to your expert opinions and your input. Thank you.
Okay, thank you very much, Erwin. Back to you, Professor Orego. Do you want to comment?
It's not necessary. It's crystal clear.
Okay, it's an excellent ending to an excellent lecture.
Agree.
So the mic is back to you again, Professor Ayman. You need to open the mic, Professor Ayman. Yes, that's it.
Now, I'm glad to introduce my dearest friend, Professor Ahmeduddin Hussein, Professor of Vascular and Endovascular Surgery in Shams University. Professor Ahmed was the founder and previous president of Vascular Society of Egypt, and he is president of Afro chapter of International Union of Phlebology, and distinguished member of Mediterranean League of Vascular Surgery. Dr. Ahmed is going to discuss venous stent and the day after, other hidden aspects. Okay, please go on, Dr. Ahmed.
My slides are visible. I'll just check. I know that we are getting late and everybody is a bit tired. So I'll try to be as quick as I can. Can you see my slides?
No, if you need to press on slide share button. Which is a green button at the end for a slide share.
I'm trying now. I can hear you, but I lost the big zoom screen and I cannot see the rest of the panels either. Mr. Khalid probably would give us a help.
Can you maximize the zoom screen? That's it. Now we can see your desktop. You need to share the PowerPoint presentation, not the whole desktop.
Should I exit the minimized video? Because I have it in minimized video.
You have your presentation on PowerPoint, isn't it? And you done the prova.
Can you see it now?
No, we only can see your desktop. We can't see the PowerPoint presentation. If you open the PowerPoint, if you open it now in your desktop.
Yes.
Can you press on the PowerPoint?
I'm having it and I'm going to try the slideshow. I got the slideshow, but I lost the big zoom screen. Now I have a smaller screen which is minimized. And there is on the right side lower quadrant an icon that says to exit the minimized video. Should I click on that?
Yes.
Yes, now I can see the big screen. So I'm going to share the screen. Is that so, Dr. Omar?
No, we can't see it yet. I think it mentioned that we are sharing Professor Orego's screen. So if Professor Orego can close the screen, yes, and you can start sharing Professor Ahmed.
I'll press on the green one, the green
press
button.
on the green one, yes.
Hold on 1 minute. Orego has to close his
Orego
screen.
Orego already closed.
Oh, that is why. Okay, sir.
Okay. So if you can
Just a minute. Now it's coming.
Are we set?
Yes, then we can see your PowerPoint, yes.
Okay, sir. I'll start the slideshow.
Yes.
Now again, hello everybody. First, let me start by thanking Servier and Prime Partners for providing the platform, and of course, dears Professor Al-Farouk and Fakhri for an outstanding, relentless effort for the last few weeks, providing us with these unique opportunities.
Dr. Ahmed, you need
I have no
to
disclosures.
maximize the slides. Just press on the slideshow.
Yes.
Are we set?
Yes, yes, we are set.
Okay, guys.
Great.
I have no disclosures, just my passion for endovascular interventions. Now, if we look at the rationale this is my agenda first. We are going to highlight the rationale for stenting. How could any stent fail, including the venous stents, the concept of biocompatibility, and the impact of that on stent failure, on patency, the rationale for adjuvant pharmacotherapy, the future trends, and finally the take-home messages. About the current status, cardiac and peripheral endovascular interventions are now definitely more liberally used than 3 decades ago, with variable outcomes and patency rates. Improvements in the stent material and design, together with the now liberal use of anticoagulation and dual antiplatelet therapy, have improved both stent safety and efficacy. However, I'm going to come to that soon. The optimal biocompatibility and long-term efficacy remains elusive, no doubt about that, especially in the absence of adjuvant pharmaceutical intervention. So, this is quick. My take-home message number 1 is that stents, once deployed, they have to be assisted after deployment. It's a huge business and still growing. And that is why we use any stent. We have to have a mold in the vessel and to have an endovascular support. You all know, of course, the indications for stenting on the venous side. That's iliocaval occlusion, adjuvant procedure, post-catheter directed thrombolysis in massive iliofemoral DVT, and of course, in the upper arm and central veins, long-term indwelling catheters in hemodialysis patients. Venous stents are no exception from the inflammatory insult or the biologic inflammatory response of the venous wall. Consequently, they can induce negative remodeling, they can induce thrombosis and neointimal hyperplasia. How could a stent fail? Any stent. Any stent could fail because of fracture, stenosis, thrombosis, and migration. The big question is, why does that happen? Which takes us to the concept of biocompatibility. Biocompatibility is usually a broad term used to describe the interaction of the implanted prosthesis within the bloodstream. A more simplistic definition is nothing but the blood-device surface interaction, or the response to the degradation products of the bare metal stent. Now the concept of biocompatibility is moving from a do no harm to one of doing good, that is encouraging positive healing response. That's what we're aiming at. So let us have a look on what happens immediately post-stent deployment. In the first few seconds, in fact, which will have a huge impact on the weeks and months to follow. As soon as the stent is within the blood, a hydration layer forms. And that hydration layer would invite rapid absorption of plasma proteins, and it would trigger cellular invasion and inflammatory response as well. So bottom line is that because of the mechanical injury of the stent being deployed and the presence of metal itself, an inflammatory response occurs, which would trigger coagulation cascade activation, inviting cytokines, and through certain signal transduction, smooth muscle cell proliferation can occur. So having said that, we all know that bare metal stents are inherently thrombogenic, and that's the rationale for adjuvant anticoagulation and antiplatelets in many, many centers. Would that have an impact on the patency? We're going to see together. We looked at our registry at Shams in my institution for the last 20 years, and these are the patients that could be really followed up with variable periods of time, because not all the patients are compliant and they do not always come back for the follow-up. Different territories, arterial and venous. We are talking now about 79 venous stents during that period. The follow-up was non-uniform, ranging from 4 to 46 months, different complications, including restenosis, thrombosis, and migration, a couple of stent fractures actually. And those complications could occur at 8 months to 3 years. The vast majority of the venous stents were in the iliac territory and in the central veins in nominate and superior vena cava. Now, this is interesting because when we followed up our patients, we found that the majority of the patients, of course, in fact, all of them received anticoagulation for the first 6 to 12 months. Another group, we added dual antiplatelets, especially in the first 4 weeks, and aspirin for the 12 months. That was left actually to the vascular surgeon's choice, depending on the nature of the patient, background, comorbidities, and the map of the lesion, of the occlusion, actually, the venous occlusion. Concerning patency at 12 months, again, this is interesting. We found that in group B, who received anticoagulation alone, patency, primary patency was 89%, while in group A, in which we added antiplatelets, we had 90.6% patency, primary patency, which was by its own statistically insignificant. However, a very interesting finding in these cases, when we looked carefully at those patients who could make it till 40 months, 40, follow-up, we found that these were 12 patients. That actually was actually driving us to start just last month a new study on those patients who were followed 40 months after venous stent deployment. And in group B, there were 5 patients, and in group A, that's anticoagulation plus antiplatelets, these were 7. All the 7 from group A maintained their primary patency, which means they maintained their biocompatibility. And in group B, 3 out of the 5 lost that primary patency. So that's an interesting finding to our team. Some of our cases, I will go quickly through them for the sake of time, before and after. What about the literature? If you look at May-Thurner syndrome, published series, primary and secondary patency rates were 84% at 19 and 93% at 20 months respectively. Iliocaval venous stenting, more than 60 patients. Overall primary and secondary cumulative patency rates at 12 months, 70% and 92% respectively. And after stent placement, as you can see, 97% of patients received anticoagulation. In addition, 61% of them received antiplatelet prophylaxis with aspirin, clopidogrel, or combination. So you can quickly notice that there is no worldwide consensus on the usage of both anticoagulation and antiplatelets together. So this finding really warrants further research for the underlying mechanisms leading to venous stent thrombosis and implications of that on the optimal management strategy. So what about the future trends? Companies are still working on improving stent material, open cell design seems to be reasonably optimal. New alloys combining titanium and others, and of course the drug-eluting stents. Is there a role for bioresorbable stents in the venous side? It seemed promising in the beginning, however, out of some trials, the Absorb 3 and 4 trials by Abbott, and we are talking now about everolimus, not paclitaxel. It had its limitations at 2 to 3 years, and we found that the early benefits acquired in the beginning were lost, and hence the liability to stent thrombosis. And after FDA approval in 2017, they were taken off the market in 2018. So probably we're still having a long way to liberally embrace the concept of bioresorbable stents on the venous side. In conclusion, venous stents are liable to all stent post-deployment complications. Currently, there is for sure no single stent which is 100% biocompatible. Consequently, an in-stent thrombosis and occlusion remains a potential threat. Anticoagulation in the first 6 to 12 months following venous stenting, with particularly a low molecular weight heparin in the first 2 to 6 weeks, seem to be much recommended or advised. And there's currently no consensus regarding the post-procedural antithrombotic therapy, although we are more and more convinced with the rest of my group at Shams to use antiplatelets in the first 4 months. But anyway, I do believe that further research is warranted. Lifelong anticoagulation is recommended post-stenting in case the venous occlusion was preceded by multiple prior DVTs, and discontinuation of anticoagulation after 1 year or maybe even shorter is advised following venous stenting for the single acute attack of DVT. And in most centers worldwide, venous stenting so far is giving us satisfactory 6 to 12 months patency. Long-term effects and patencies are still being awaited. What about the long-term results? For venous stenting, I do believe that we have to follow the proper indications, because I think we have to bear in mind also the liability to post-thrombotic syndrome. And the panel of top experts know better than me that abolition or totally avoiding post-thrombotic syndrome is not possible. It's just not possible. We try to minimize the post-thrombotic syndrome, but not get rid of it. Also, careful regular follow-up is mandatory. An adjuvant pharmacotherapy is a must. Anticoagulation for sure, antiplatelets in some centers, including mine, in the first few months, especially in high-risk group of patients, those who develop DVT and then deep vein occlusion afterwards in groups of obese patients, malignancy patients, and those with a positive past history of multiple attacks. So now the key word, again, is to ensure a sustained biocompatibility. That's crucial. I thank you very much for your attention.
Thank you, Dr. Ahmed. It was a great presentation, and thank you for being kind. It was great. Thank you. I think we'll have a few comments from our panel. I will start by Professor Ahmed Kursat Buzkart from Turkey. What do you think about the lifelong anticoagulation, Professor Ahmed?
You need to open your mic, Professor Ahmed.
If you don't mind, I'd like to pass this question to Suat Doğancı. The reason is Suat improved for the deep vein system very much better than me. And please, Suat, do answer this question, because he's really an expert for deep vein pathologies in our country now.
Thank you. I appreciate. Dr. Suat, can you answer?
First of all, I want to thank Dr. Kürşat Bozkurt for giving such words about me. And again, thank you very much for giving the opportunity to answer this question. Especially the venous stenting, when you think in global, it has a lot of different concepts. But let's start from your question about the anticoagulation. When you look at the literature, there is no current consensus about anticoagulation after deep venous stenting. And the last guideline, maybe we can accept the Dr. Ellen Davis group, is the Delphi consensus guideline. We can have some words from there. But when you look at the ACCP guidelines, especially the 2012 and 2016, there is no information about anticoagulation after deep venous stenting. And in the CIRSA guidelines, there is only recommended the warfarin after venous stenting, which should you have higher levels, like around 3.0 INR levels, you should use it. But especially in the current literature, now we begin to have also some promising results using the DOACs. But which one we should use is just dependent on the underlying pathology. If it is just a compression syndrome that you make the stenting, after stenting, I think it is recommended to 6 months of anticoagulation, and then maybe you can continue or discontinue. It is up to you or your protocol. But if there is an extensive disease and it's a post-thrombotic syndrome, and if you have a multiple previous DVTs, then you should give a lifelong anticoagulant therapy. And if you have an extensive stenting like the Keva-Bieliak or some other type of stenting, I think it is recommended also to add some antiplatelet therapy, those venous stenting after the procedure. So that's why there is no one-size-fits-all anticoagulation therapy. You should adjust your anticoagulation protocol according to what you stent. And also in the Delphi consensus document, especially for the first month, it is recommended to use solely the low molecular weight heparin. But if you have some, let's say, idea or experience, you can also, now we have the good results, you can also go on with the DOACs. But I want to again press on it. The underlying pathology is much more important that you decide your anticoagulation protocol.
Can I also comment on Dr. Swat?
Yes.
It was quite informative. Can I?
Yes, sure. Go on, Dr. Ahmed.
Yes. I couldn't agree more with Dr. Swat's also remarks or comments. But having mentioned the potentially beneficial role, of course, of anticoagulation post-stent deployment, if we compare, and I'm talking about the initial period, the initial 4 weeks, low molecular weight heparin and DOACs, I think there is some superiority of low molecular weight heparin versus DOACs because DOACs lack the anti-inflammatory effect of the low molecular weight heparin, and there is more rationale of using low molecular weight heparin in the first few weeks. Then maybe later on DOACs.
Yeah, I also tell the same, Dr. Ahmad, because especially as I told in the Delphi document, it is recommended to use low molecular heparin in the first period. But there we have now promising results with the DOACs. So DOACs are now having also good results, but it's too early to give a clear-cut decision about this.
Yes, you have a point, Swat. Now, may I ask Dr. Lobato, Armando Lobato from Brazil, what's the situation in Brazil regarding the venous stenting? Do you keep them in anticoagulation for how long?
Thank you very much for the question, and I'd like to congratulate you. That's a very elegant presentation regarding venous stents. We do use a double antiplaque therapy for 2 weeks, and we're still using a Xarelto anticoagulation for 6 months. And if the patient has previous DVT, we keep for long life the Xarelto, the anticoagulation. But I do have two technical issue questions for Professor Kuhl. The first question is, do you think that, for example, the oblique stent, the venous, the sinus oblique stent, is because this the format is better for the iliac bifurcation, avoid to cover the contralateral iliac vein? Do you think it's some advantage to use that? And the other question is, when you have a DVT in the iliac vein, what's your procedure? You use what catheter to remove the thrombus? And if you do that, use a vena cava filter to avoid pulmonary embolization.
Great. This is a very good point. May I ask Dr. Sergio, what you prefer in keeping a patient after stenting? Use in the prevention of PTS, do you use stocking after stenting together with keeping anticoagulation, or what's the policy in Italy?
Well, it is variable by center, of course. We use stockings, of course, even before, as you know, we are like really in support of the concept, even if we know that recently there are given new investigations that are quite contradictory on the topic. We also use surodoxide. That is a question I had for the panel, how they see about this drug, that is basically a glycosaminoglycan, because as was pointed out nicely, there is an inflammation of the wall that could benefit from a restoration of the glycocalyx. So since we have big experts like Swat and all the others, Professor Lobato, so have you ever had experience with this drug that was actually validated in a nice paper of Circulation 2015, that is heparan and dermatan sulfate, and that could have some benefits in a situation like this?
Great. Great. This is very nice to hear about.
So
this.
is there any expertise over there about this surodoxide? Do you have any experience in your countries, or Swat or Armando?
I think some of the panel have experience with the sulfatoxis.
Surodoxide, yes, it has been.
Yes. Do you have such experience, Dr. Ahmed?
No, in fact, not at all. But I know that the group from Padova in Italy published several times with Professor Giuseppe Maria Andreozzi on that, and seemingly it has proven obvious beneficial effect, not really in those cases that are liable to post-thrombotic syndrome, but to improve the all-over chronic venous insufficiency syndrome. However, for I don't know why, but for logistic reasons, Professor Fakhri, it was not registered by the company in Egypt, as you know.
It would be interesting to look at these properties on because they indeed looked at the reduction in the post-thrombotic syndrome incidence in these cases. So maybe future food for thoughts.
That's quite interesting, Sergio. Thank you.
Yeah, it is. It is. It worth try, and we'll ask you to bring the drug to Egypt. Omar, do you have a few questions?
We can have one question from Dr. Ahmed Onsi, who raised his hand. We can open his mic. Dr. Ahmed Onsi, please introduce yourself and ask your question. Dr. Ahmed, can you hear me? Yes, introduce yourself, Dr. Ahmed, and ask your question. Can you ask your question? Or there is a problem with the mic? I think there is a problem with the mic. You can take the next question.
Can I have a question, Dr. Omar?
Yes, please. Please, Dr. Mahmoud, go ahead.
Thanks a lot, Dr. Ahmed, for this very nice presentation. Actually, we are following the same protocol of anticoagulation. We give a low molecular weight heparin, then we go anticoagulants, this new oral anticoagulants for at least 6 months. But my question, does it make a difference if you are treating just a May-Turner syndrome or a post-thrombotic, post-phlebitic occlusion of the iliac vein? Does it make any difference in your protocol of anticoagulation?
I thank you for the question, Dr. Mahmoud. And as usually, I expect these kind of tricky questions and difficult to answer from your side. But the patients with previous thrombotic occlusion probably would lift off your shoulders some concern as far sorry, the patients from May-Turner, not the post-thrombotic, would lift off your shoulders some concerns about severe post-thrombotic syndrome because they're simply not post-thrombotic. So, having said that, we tend to shorten the duration of the anticoagulation in those patients and not go for a lifelong anticoagulation because there is no obvious benefit, at least in my knowledge and in the literature. We probably do not become so much enthusiastic about adding a longer term, if ever we're going to add antiplatelets. So in essence, in response to your question, the nature of the pathology, the initial pathology, yes, it does have an impact on the treatment strategy, but probably not the core issues, which is using adjuvant pharmacotherapy, because I have pointed out that in the presentation. Stent is there, so we have to protect the stent. We cannot just leave the stent without a protection or assistance. I hope I've answered your question.
I will take one final question from a panelist, Dr. Badi. Your mic is open. Yes, please go ahead.
Yeah, thank you, Dr. Omar. Dr. Imad, you very correctly pointed out that the indication should be, I think that was the first point that you said. So I agree with that. We are treating arterial and venous, most of us. And the mindset is different for arterial and for venous. In arterial, you're looking at stenosis and perfusion. In venous, even a 13% stenosis will produce a back pressure. So now my question is, how do you ever use IVUS? One, for deciding whether to open and stent it, and two, to decide whether you put in a stent and you want to, should you post-dilate it or not? So my question is regarding importance of IVUS.
Yes. Thank you, sir, Professor Bedi. IVUS we used with my team in a minority of cases for the simple reason that our institution was quite reluctant to acquire the IVUS, so we did not use it routinely, mainly because of cost issues, actually. The situation has become worse nowadays because of the global crisis of the COVID-19 and cutting down the expenditure in the whole health establishments. However, I do believe, out of the experience of other colleagues in other centers, that IVUS would help not only in properly deploying the stent with the proper apposition to the wall, but also to check on the upper and lower parts of the venous side where we are treating for any residual either flaps or a tiny thrombus which is starting to form. So that concerns your first question. As far as the second one, which was related to post-dilatation of the stent in the venous side, we usually make sure there is a post-dilatation, especially in the lower iliac segment, But again, that's a function of the type of stent you are using, because some stents, as you know better than me, like wall stents, they have larger sizes that seem at the end of the venographic appearance quite fitting as smoothly outlining the wall, and others would need probably a bit of post dilatation. So it is not routinely done. At least
thank you. That final question. Okay, Professor Suat, go ahead.
Actually, I want to talk about the post-dilatation. It is crucial to make a post-dilatation when you do a venous stenting procedure, because especially in the let's say post-thrombotic patients, you know that these are very let's say very fibrotic veins, and they are very becoming tiny. And if you don't post-dilate, any stent cannot open to its desired stent diameter. So it's not an usual, but you have to do it whenever you do a venous stenting procedure. Otherwise, your stent never get open fully. It's very important.
And use a high-pressure Atlas balloon, or use something different?
Especially the mostly used post-dilatation balloon is Atlas balloon, but if you don't have, you can also have some cheaper esophageal balloons, larger balloons. You can also use that balloons in your practice. So it is important, and especially for the IVUS, if you have it, you have to use it, because it's very beneficial, not only deciding the stent placement areas, but also it decreases the amount of radiation exposure for the surgeon and for the patient. So it has more than one benefit. If you have it in your armamentarium, you have to use it. I advise it. And as a last comment, I have to focus on it. For the venous stenting, patients shouldn't be accepted as one. You know that Dr. Jelai has presented his classification. So it is, for example, we cannot compare, let's say, simple May-Turner patient to an extensive disease class 5, and both inflow vessels are involved. So that's why our stenting practice and our anticoagulation practice is changing solely or mainly depending on the underlying pathology. This is very important. We should take care of it. And one of the other important issue is patients with hypercoagulability problem. So in order to decide what to do, we have to take into consideration all those issues. So it is more complex than I think for the arterial side, because we are working on a low flow and low amount of blood. Sometimes in order to keep your stent open, maybe you need even one drop of blood. So we have to take care of all these issues into consideration.
Thank you very much. With this great comment, yes, do you like to add comment, Professor Ahmed?
Yes, in fact, passing through an occlusive lesion in the venous side, you all know that it could be even more tedious than the arterial side, because you are just traversing trabeculae, not really a plaque. So that's why it takes me to my question to the rest of distinguished panel members and to all of you. Do we have a consensus on the amount of oversizing that we use? Are we talking about 15% oversizing, more, less?
Okay, I will take, let us say, 30 seconds with each of the panelists. A quick, let us say, Armando.
Yes, it's a very interesting question. I have some cases that have complication with the vena cava filters in the patient with a previous venous stents. In two of these cases, you can see the struts of the stent outside the vein wall. So in this patient was used at 20% of oversizing. So my idea is to use less than 20%, something like 15% or 10% and 15%, because I did have this kind of complication.
Okay, Professor Bosgaard, within 30 seconds. Professor Bosgaard, if you can open your mic.
Yeah, I'm here There was a very good discussion. There was a good program, specifically deep veins, superficial veins.
So your opinion about oversizing?
Say again?
Your opinion about oversizing?
Oh, sorry. I was thinking 10 to 20% would be fine.
Excellent. And Professor Ufuk, how much oversizing do you do, if you do?
I open my microphone. My opinion is the same as the Kürşat, and then as he said before, our expert is the Suat Doğancı. In our team, he deals with the deep venous system and the stenting, and then he's saying is my opinion also.
Okay, Professor Loyal Kabnik.
Thank you for the opportunity. I think it depends on what type of stent you're using. If you're using an alveolar stent like a wall stent, we talk about 20%. If we're talking about using a nitinol stent, we're talking maybe 1 millimeter more than the size of the vessel.
Okay, Professor Badi, how much
rule of thumb 15%, but then again you individualize quite a lot.
Okay, and Professor Swat, what do you do?
Actually, I also agree with Dr. Kabnik, but it is much more important to decide your size before going also into the operation or during the operation by using IVUS. You can have some correct sizing. This is important. And one of the other issue, if you have too much oversizing, believe me that those patients are having real post-stent pain. That's why this is also an important issue. If you have too much let's say larger stent you use, those patients are having too much post-stent pain. And also before the operation with the duplex and with the other diagnostic tool, even if the one side is let's say free from disease, you can try to measure that vein to have your stent size. And also you can also still have one opportunity with the balloon sizing during the procedure. So these are all important issues that you can use as a trick for sizing. This is important.
Okay, that's a great end of consensus. So it is back to you, Professor Ayman.
Thank you, Omar. It was a very nice discussion, as usual. Thank you. Now I have to thank Survey Company and for sponsoring this meeting. I would like to thank Professor Alvaro Orrego, Ufuk de Merklik, Ahmed Hussein, our greatest speakers. Also, I would like to thank Dr. Armando Lobato, Dr. Sergio Janizi, Dr. Harbit Singh Bedi, Dr. Ahmed Kursat Buskar, Dr. Loal Kabnek, Dr. Swat Degansi, Dr. Victor Kanata, Dr. Mahmoud Salahuddin, Dr. Martin Mersch, and of course, Dr. Mark Whitley. I thank you all for joining us. Before I go, I would like to share with you, this is our program for the whole of May and June. Please mark your calendar to join us every Friday evening. This will be great. Also, I would like to remind you by our next webinar meeting. We have Professor Luigi Antoniani from Italy, and Professor Ahmed Kursat Uzkart from Turkey, and Professor Ashkan Hagshams from Emirates. Please keep the calendar and always stuck to our meeting and join our non-profit webinar program. Thank you, our partner of success, Prime Partners. Thank you. Thank you all. Please keep safe and stay safe, and see you next Friday. Good night.
Thank you very much.
Thank you. Thank you very much.
Thank you all.
Stay safe, everybody.
Bye-bye.
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 خلصت